I'm pleased to introduce our second speaker, Dr. Howard Ovens. He is an emergency physician and Chief Medical Strategy Officer of Sinai Health System in Toronto. At the University of Toronto, he holds the rank of full professor at the Department of Family and Community Medicine and is a senior fellow in the Institute of Health Policy Management and Evaluation. He is the Ontario Expert Lead for Emergency Medicine, and in that capacity, he chairs the Emergency Service Advisory Committee, and as part of the pandemic response, sits on the Ontario Health R5 response table representing emergency medicine. Dr. Howard Ovens is also a member of the Public Affairs Committee of the Canadian Association of Emergency Physicians. He tweets about issues in the administration of and public policy related to emergency services using the handle @HowardOvens, and his blog, Waiting to Be Seen, is hosted on the Emergency Medicine Cases website.
Thanks very much to Juana and to Spark and to our co-chairs and sponsors and to the audience for joining us today. I think it looks like it's going to be a very interesting day. I don't have any conflicts of interest to declare, and I'm going to provide a very Ontario focused, somewhat personal and emergency department focused presentation, and I hope to leave lots of time for questions. I've got my email up there. If we don't get time for your question today, please feel free to email me. And I should say that when Juana first invited me back last fall, I had one idea in my head of what this talk would be. The world's been changing rapidly. I thought I had settled on my slides and talk last week, and I woke up at 3 in the morning in a bit of a sweat and thought, no, I've missed the mark, and changed all my slides this morning. So hopefully I've got a presentation that is relevant to what's going on in our world today. And I thought I'd open with this quote because it's very familiar to all of you. The only thing we have to fear is fear itself. I think that part of the theme of my talk will be balancing fear and evidence. Fear is not necessarily a bad thing. It concentrates our mind. It makes us vigilant. It motivates us to be on guard and careful, but it can also lead us astray. So we're going to talk a little bit about balancing fear and evidence. And I wonder how many of you can recognize that picture. That was clearly the backdrop shows you that it's the Blue Jays at the Sky Dome, but that's not this year. We haven't had any baseball this year. It's 2003 during the SARS outbreak in Toronto, which Toronto was badly affected by the SARS outbreak in 2003. However, we didn't have the sort of lockdown that you have now, and mass gatherings continued, and people took some things into their own hands, including the mask you see on this fan. My emergency department at my hospital was very active in SARS management. We admitted over 20 active SARS patients through my emergency department without any transmission to patients or staff, and that certainly has been embedded in my DNA about how we manage things, especially this pandemic. Just to show you how things have changed, this is another shot from the spring of 2003 at my hospital. It was also a cold and miserable spring in Toronto, and we did institute pretty early on door screening. We took temperatures, we asked people about symptoms, but to show how kind of rudimentary our infection prevention and control practices were, to let everybody in out of the cold, we allowed a bit of crowding that really was totally unsafe and impractical and not what we would do today. Today we built hoarding outside the hospital and installed heaters so that we could maintain physical distancing during screening. This is a screaming headline from a Toronto Daily during that period. And the media are interesting at times like this. They serve a very important purpose in getting the facts out there. And most of our regular media, newspapers, the Globe and Mail in Canada, New York Times, Washington Post, CNN, do a very good job of getting the facts out. But the nonverbals, the 24-hour news cycle, the huge font headlines, do contribute to an atmosphere of fear, which we must acknowledge and make sure we counter. After SARS, there was a lot of soul searching in Canada. I was part of a committee that looked at the implications of SARS for Canadian emergency departments. And at Christmas 2019, just before the pandemic, where had things stood in respect of the changes we made after SARS? Well, some things we maintained reasonably well and have helped us cope. For instance, our EDs are much better designed for infection control, airborne isolation rooms. We really strengthened and Dr. Barbara made reference to the developing profession of infection prevention and control. And certainly most of our hospitals have very strong IPAC departments, which has helped us greatly keep acute care safe. And I think the basic knowledge of our colleagues, doctors and nurses working in emergency departments, is much better than it was when we first started to deal with SARS. At that time, most of us didn't really even know what contact and droplet precautions meant, much less how to safely don and doff. In the period between 2003 and H1N1 in 2009, Canadian hospitals developed pandemic plans. Most of them developed pandemic supplies. I think the maintenance of those was mixed. I can tell you that my hospital, after our SARS experience, maintained our pandemic supply of PPE, and that helped us a great deal. And of course, as a result of SARS, we created the Public Health Agency of Canada, which has also been an asset. A few things have been allowed to slip over time, most notably our funding for public health, especially investments into information technology for public health, which has really held us back in the efficiency with which we can test and report results, our ability to do contact tracing and monitor isolation. We're mainly very manual, using a lot of paper, pen, fax, telephone. And certainly governments allowed pandemic supplies to expire, and both of those things have caused ongoing problems. A couple of just brief notes about the differences between the original SARS virus and the SARS coronavirus 2, which is what we call the current virus. That's the name for the virus. The disease, of course, is COVID-19. They, without mitigation strategies, have similar transmission with R zeros of about 2 to 3. That means that the average person infected, if there is no mitigation strategy in place, will pass on their virus to 2 to 3 other people, which leads to exponential growth, but is more typical of droplet diseases such as flu, which has an R naught of 1.3, whereas airborne diseases have logarithmic growth with R naughts, like for measles, in the 10 to 12 range. But the big difference between the first SARS virus and this one is when the viral load and therefore the contagious risk maxes out. In the original SARS, it was late in the illness when you were critically ill with pneumonia, short of breath, coughing, and by that point you were usually in hospital, where once we figured out how to manage these things, both identifying and containing them safely, we were really able to eliminate the SARS virus pretty quickly from the world, whereas this virus is more contagious early on, pre-symptomatic, when you're still well enough to be ambulatory, and that has led to an army of invisible spreaders of the virus and led to the quick global spread. The case fatality rate is lower than the original SARS virus, but much higher, at least one log higher than, or one order of magnitude higher than influenza. We see even higher case fatality rates in many countries, including Canada. This is usually a factor of both how much testing you do, which determines the denominator, and the nature of your outbreak and your population, and where you've done a good job of community lockdown, as we generally have in Canada, but we've done a lousy job of protecting our frail elderly. You get very high death rates in those people who do get infected. And we had controversies during SARS, which are the exact same controversies we're having today. Is it airborne or is it droplet? Which procedures medically aerosolize the virus, leading to greater transmission risk? And how effective are the PPE advice that we're being given by our IPAC colleagues and colleagues in the World Health Organization? So January 25th, I was watching the situation carefully because it was so evocative of our experience in 2003. And by January 5th, it seemed to me that this was coming our way and we better get ready, including shaving my beard so that my N95 mask, if I needed it, would seal to my face properly. And my Twitter audience is mostly colleagues in emergency practice. And so I thought, well, I'll remind everybody that they need to shave and get ready for this virus, and I'll try to instill some esprit de corps. So I challenged people to do the opposite of what we do in sports. You know, baseball and hockey teams often grow playoff beards to bring everybody together for the hard push through the playoffs. And I thought we'd do a playoff or a pandemic shave and keep ourselves clean shaven until we safely got through this. Well, I learned two things from that post. One, many of my younger colleagues thought I was crazy. They didn't think they needed to shave, didn't understand the mask fit test and the importance of being ready to intubate patients with this virus. And Twitter loves controversy. So this thread got a lot of play. It really went viral, if you will. And but I'm happy to say that when it all settled, many people went back, did some reading, talked to their colleagues, and there were a large number of posts of people who decided that they would shave and shared their photos. So at least on January 26th, we still had significant need to brush up on our IPAC routines. The big question, are our emergency departments safe? And I'm going to address this mainly again from the Ontario perspective, because that's the one I have some responsibility for and feel most familiar with. Well, first of all, I'd like to show some local evidence. This is ER visits by month in Ontario since 2008. It's displayed month over month for year over year because of seasonal variations, mostly due to the flu. So the nature of this graph is that with constantly rising volume, you would get a series of constantly rising parallel lines going up the graph. And we have something pretty close to that. This fiscal year that ended March 31st is the top line in brown. The red circles are months where we had a record high for that month. And then you see what happened. March 13th, we had a lockdown. The last couple of weeks of March, volume dropped precipitously. And that was one big impact on whether our departments would be safe or not. We'll talk more about why that happened in a moment. This is another graph we look at monthly at my committee. It's the number of patients who were sleeping in the emerge all night waiting for a bed. And we're still there at 8 in the morning. It's a measure of patient experience and crowding in our emergency departments. And if crowding continually gets worse, then these lines will climb up the page. And the purple line, which is last fiscal year, you can see almost every month we had record numbers of boarded patients in our emergency departments in Ontario, but that fell off a cliff on March 13th as well. So almost overnight, by shutting down elective care, we pretty much solved our crowding problem. Our colleagues went further. There's been a lot of news in the media and a lot of talk on social media, especially in March and early April, about the dangers of healthcare work and what heroes we are, but also what measures some of us are taking. There are a lot of stories of our colleagues doing dramatic things to keep their family safe, like stripping naked at their front door and making a dash to the shower in order to avoid shedding any virus. This isn't really necessary from an evidence-based perspective because clothing is not a vector for this type of virus. The virus requires moisture, and so surfaces that are impermeable, firm surfaces, metal surfaces, can keep the virus viable for long periods. We're not sure how long it actually transmits from those surfaces, but at least the virus is alive. But porous surfaces that absorb water will kill the virus very quickly. Similarly, even though this virus is in the community, not just in the hospital, and even though in many cases the highest risk person in the home for complications of COVID might be the healthcare worker rather than their children who, if they're healthy, probably are at relatively low risk. Many people separated from their families, sleeping in the basement or moving out altogether. I've blacked out this physician's name because I don't want to pick on him. I've said that fear serves a purpose. I've said that fear can, in fact, help us feel safe as well as keep us vigilant. But even this story says, the Parton highlighted, this move goes beyond public health recommendations as we see this physician, emergency physician who moved out of his home, but he's making a visit to his spouse at a safe physical distance. There have been a number of other fear-driven controversies that I won't go into in much detail, but I've talked briefly about the amount of energy that goes into arguing at the margins about whether chest compressions are aerosol generating, whether even N95 masks are protective, or do we need PAPRs, those are the spacesuits, powered air purifying respirators. The problem with PAPRs, I learned during SARS, is they're very safe and comfortable when you're in them. They're very complex to doff, and that's when you're at the most risk for getting contaminated. And I don't think they're appropriate for situations where you have to take them on and off frequently. We've argued about what the role of the older physician should be, how much care should we provide in situations where there may be very little benefit to the patient, with extremes of standing back when we really should be giving care, to diving in and providing care at great risk to oneself, where there is very little likelihood of benefit to the patient. And of course, there's been a lot of bandwagons over treatments that have very little evidence to support them. Hydroxychloroquine has probably come and gone to them for the most part already, although I'm involved in a trial in our hospital and at the University of Toronto in using hydroxychloroquine in a placebo-controlled trial to prevent COVID-19 infection in healthcare workers. Remdesivir, similarly, I think the information from the White House and Dr. Fauci, although I respect him greatly, I don't think it's the game changer from the data I've seen, and in my opinion, should still only be used in a clinical trial. So I asked, are our emergency departments safe? For Ontario, I think the answer overwhelmingly is yes. We have not had outbreaks in our EDs. We have had some outbreaks in our acute care inpatient wards. We've had healthcare workers get sick in long-term care facilities and to some extent in acute care facilities, but I haven't heard any anecdotal evidence of healthcare workers getting sick in our emergency departments, and by and large, emergencies colleagues have become much more relaxed at this stage after having seen that they're not getting sick and that they're not admitting sick colleagues. Well, why are our departments safe? I mentioned volume decreases are important. They limit crowding in the waiting room and in the hallways of our emergency departments. The volume decrease was driven by a combination of public fear and in some cases good citizenship, virtual options to get advice instead of coming to the emergency department, and definitely the COVID assessment centers as another option for testing and assessment for low acuity cases has been very helpful. I think clearly our precautions work, that for the majority of situations, droplet precautions do work, and as well, so far our PPE supply, although we've had to steward it carefully, has been maintained, and we've really ramped up staff training, and our practice has avoided, for the most part, avoidable aerosol generating procedures, except those that we must carry on with, such as the so-called protected code blue. We've also benefited from a short length of stay in emergency departments for our admitted patients, especially the COVID positive cases, and that reflects both the creation of the hospital capacity I called out and the commitment from our hospitals to get these patients up into proper isolation rooms on the wards or the intensive care unit, and the fact that our hospitals did not get overwhelmed because of other public health measures, mainly physical distancing. I compare that with the experience in other jurisdictions that did become somewhat overwhelmed, Wuhan, Northern Italy, New York City. I qualify my comments by saying I'm only aware of what I've seen in social media and in media more generally. We don't have very many peer-reviewed reports as yet, but there were reports of a lot of emergency workers getting ill in these areas, and at times, from what I could tell, their emergency departments were crowded, with COVID patients being cohorted for long periods in the emergency department because the hospitals were full. PPE supplies were not always fully maintained. Staff practice may have been compromised by a number of things, including the lack of time to prepare with when they were hit by the pandemic, the compromise in practice, what that can occur when you recruit outside workers, including retired people. And from what I could read, what I think is really heroic and perhaps inappropriate use of aerosolizing procedures when you are in a compromised situation with respect to PPE and distancing of patients. These most notably include the use of non-invasive ventilation, perhaps even high-flow oxygen, and certainly CPR in most COVID-suspected patients with pneumonia who have a cardiac arrest versus a respiratory failure. They're unlikely to have success with CPR. Will our ED stay safe through the next months and perhaps a year? There are a number of threats on the horizon. Emerge volumes we expect will rise, perhaps not back to normal, but that will put a lot of stress on our departments for flow and safe distancing. And I think the mitigation strategies are to maintain our COVID assessment centers, to maintain virtual options for patients to find out if they need to come to the emergency department, and to some extent, hospitals should look at their disaster plans and increase space where they are able to. As we ramp up care in our hospitals, especially surgical procedures, we expect decreased capacity in our hospitals, which could lead to longer length of stay for admitted patients. In Ontario, we've asked hospitals to stay at 85 to 90% occupancy. Will we be able to do that? And I've challenged people on my committee to encourage our surgeons and hospitals to finally move to a 7-day-a-week scheduled surgical model to even out the peaks of crowding that occur usually midweek because of the 5-day model. We have to keep an eye on our PPE supply. Will our staff fatigue with precautions over time. And here's why I emphasize the need to be evidence-based rather than too fear-based, because I fear that your fatigue could be hastened if you voluntarily adhere to excessive precautions. And if you only do that which is really important to do and which really does keep you safer, you're more likely to be able to sustain those things over time. I'm very nervous about the flu season coming this fall and winter. The only things we can do about it are mount a very aggressive flu vaccination campaign, try to enhance our testing of both COVID and flu and our surveillance for both. And our hospitals need careful capacity planning, and that will require us to do a lot of thinking about the long-term care situation and how we manage our alternate level of care patients. Finally, what are the antidotes to fear? Obviously, they're evidence from trusted sources. And I think sometimes a perspective helps, that this virus is not just in the emergency department, it's in the community. It's not going away anytime soon. And although the population risk, if you multiply even a 1% mortality rate times 30 million people in Canada, 300 million in the US, you get really potential tragic numbers. But at an individual, a 1% risk is probably not the nightmare that most of us would have without all the media hype. And also, I think if you embrace your mission, if you feel proud of the work you and your team are doing, it helps balance out the fear factor. Couple of resources there for you to share if you need some trusted resources. The CAPE website, Canadian Association of Emergency Physicians, has put out a lot of useful, relevant position statements. I love the number needed to treat website, an evidence-based site that has a lot of emergency medicine input and has a beautiful review of important questions in COVID-19 that always calms me down when I read it. And my colleagues who run the emergency medicine cases website, there's a lot of clinical and infection control information, and that's where you can find my blog. And finally, another quote about fear. If people about you are losing their heads, but you can keep yours, then you can really have a very positive effect. So thanks for your attention. I'll stop there for questions.
Before I open it up, I had just a quick question related to the threats that you brought up at one of your last slides. What do you think keeps you up at night the most? What is sort of as things prolong, what do you sort of see as the biggest sort of threat into all of this?
If I could give two instead of one.
Perfect.
I feel for our colleagues in public health. I think that they've been underfed for a long time, and the expectations on them are very high right now. But for whatever reason, I haven't seen a great deal of evidence that as the rest of society gets exhausted by lockdown procedures, as we start to open up society in the next weeks and months, we'll rely on public health to really ramp up their testing and contact tracing and isolation monitoring ability. And I fear that we're not on pace to do that. And so that's my number one threat for the next few months through the summer. And then the flu season, I think, presents real strong challenges for us ahead.
From Deborah Wiseman, she asks, as volumes climb for ED, are you considering drive-through assessments or in-car waiting strategies?
Yeah, thanks, Deborah. So I'm not personally, the emergency committee that I chair is not responsible for assessment centers. And I do think I am actually going to be on a committee later this morning for Ontario Health, which is our equivalent to the Nova Scotia Health Authority, which will be discussing the future of assessment centers from this point on. Volumes have been dropping in assessment centers because of the fact that cold and flu season is waning. And I'm going to make a case for assessment centers being maintained but becoming more flexible. Drive-through is certainly a very efficient option. I think we also need some outreach teams. And personally, I think the best way to organize them is from assessment centers out, outreach teams that can see frail elderly people in their homes. We do have outreach teams doing testing right now in long-term care. We may need them to go into other facilities. We may even need them to go into the schools in the fall if schools open up. So I would like to see assessment centers become a bit more comprehensive in their ability to provide tests, and I'd like to see emergency departments remain focused on the assessment and care of people with higher acuity illness or injury.
And Dr. Moore has his hand up as well.
Hi, Howard. A great presentation, and I really enjoyed a lot of the data that you presented there. I was interested to hear your comments about communication strategies for your provincial and local communications that you've been putting out throughout this time. If you have any suggestions to others about where they might need to participate in some of the communication for their regions or hospitals, et cetera.
Thanks, Sean. So what Sean's referring to is for emergency departments specifically, we have a table with regional representation that is now well placed in the organizational chart for the COVID response for the province. And so we have our own documents and communications that we prepare for emergency departments specifically. We also receive and pass on communications from other bodies in the response, even our medical association regarding compensation models and things like that. And we send most of those out through an email chain. One of the most important jobs our regional representatives play is maintaining an up-to-date email list of emerge directors and curating what they send out so that people continue to view their emails as important, find them in their inbox and read them. And I do think actually that we have evidence that that's true, that we are able to reach our emerge director colleagues very quickly by email. And then I can only hope, but I do trust that most emerge directors maintain good communication with their staff and keep them up to date. At the unit level, Zoom meetings have been adopted by many emergency groups, and there are also variations on that for regional tables for emerge directors where they meet with EMS and police or other colleagues. Then, so I think every region, the way healthcare is organized varies a little bit from province to province, state to state, but something analogous to that is very important. You always need some depth in your communication strategy. And so for very important time-sensitive information, we also rely on press releases, and the public media play a very important role, and monitoring the media becomes a bit of an obsession for many of us, certainly for me during this period. Social media can be an important adjunct to that, and I'd be happy to hear any other suggestions. Also, huddles on duty. Emerged physicians and nurses are shift workers, so the quick huddle at work is a very important way to make sure everybody's up to date on the latest information.
Terrific. See, we have a couple more questions in the chat. One from Delwyn Ferguson. Follow-up to Deborah's question regarding social distancing and ED, how to facilitate social distancing when numbers ramp up and we come back to normal numbers and overcrowding?
So it's going to be a challenge, and like I say, at the system level, what I'm going to push for is for the shortest length of stay for admitted patients we can squeeze out of the system to prevent crowding from boarded patients, maintaining community alternatives for people who don't want to come to the emergency department. A lot of the I'm not a big believer in blaming patients for volumes of deferrable visits, but in many cases, people come to the emergency department because they can't access another alternative. One of the blessings of the explosion in virtual care is that many virtual options are now more available 24 hours a day, so that people can get a professional opinion about whether they do need to come to the emergency department or not. Finally, once they arrive, I think we all need to look to our hospitals to make sure plans are in place to provide us with expanded space. Every hospital's Code Orange or disaster plan includes some sort of expansion of the emergency space inward or outward into the emerged driveway or parking lot, or inward to the lobby, or spaces like that. And we've got to dust off those plans and support our emergency departments to maintain safe distancing, and my hospital is doing that. And the question about the flu, there's a question in the chat box about the new normal. I think being asked about the new normal past the end of this particular pandemic, whatever the end will be, whether it'll be a disappearance of this virus or a change to a seasonal, hopefully less virulent form of the virus. You know, I can only speculate. After SARS, much of everyday life went back to normal in Toronto and at my hospital, but we maintained some of those changes I talked about in our ED design, in our knowledge and practice and investment in infection prevention and control. I think one of the most likely things to endure after this is a change in the culture around staying home when you're sick and not being so brave and tough and stoic that we're expected to show up sick. This is, I think, a change that very well might be sustained. I'd like to think that the virtual care options will also be maintained. I've got a lot of thoughts about that for emergency departments, but there are a number of barriers in terms of health human resources and payment schemes that would have to be worked out. But those are the two things I would pick out of the air so far that I would like to see sustained: staying home when you're sick, and linking virtual care into the emergency services bandwidth more permanently.